We are
Okay.
live now, ma'am.
Okay.
He will join. He will join. चलो शुरू कर दो.
Okay. Good evening, delegates. Good evening, faculties, members, and doctors. Thank you for joining Shield Connect. I'm a regional medical advisor from Shield Healthcare, Nishan Chawda, and I welcome all of you to the webinar for Gujarat Zone Obstetric and Gynecology Societies. And we invite you for the webinar on the topic NCDs in pregnancy. And the key organizer for this webinar is Dr. Varsha Baste, ma'am. So let me introduce the MOC for this webinar. Dr. Riddhi Bhatt, ma'am, is senior resident of SVB Hospital in Ahmedabad, and ma'am has done a fellowship in fetal medicine resolution fetal medicine center, Hyderabad. Area of interest is high risk obstetrics and fetal medicine. So I will hand over this session to Dr. Riddhi Bhatt, ma'am. Thank you so much.
Thank you, Nishan sir. I would like to thank the organizers for giving me this opportunity to be a part of this very informative webinar, which deals with non-communicable disease in pregnancy. And it is my privilege to introduce Dr. Varsha ma'am. She needs no introduction. She has received multiple accolades and awards from bodies around the globe, like Dr. Anandibai Joshi Award, Champions of Foxy Award. She has a very vast experience in the field of obstetrics, gynecology, and IVF, spanning more than 30 years. Currently, she is practicing in Nashik. She is the director of Baste Maternity Center and Pushpa Fertility Center. Over to you, ma'am.
Thank you, Dr. Riddhi Bhatt, for such a nice, crisp introduction. So kind of you. Thank you so much. Welcome, dear all delegates and my faculties for coming over here, and I welcome you all for this prestigious, important webinar. We have started with webinars in Gujarat already. We have covered 2 webinars in Gujarat in different zones. So this is the 3rd webinar, and there will be one more webinar in the next fortnight. Now, NCD in pregnancy is very important topic, because previously we used to have many infections and we used to discuss that during pregnancy, hepatitis A, whatnot, tuberculosis, everything. But nowadays NCD has become like pandemic, endemic, and India is the really capital of diabetes. So non-communicable disease is really a very large burden on pregnant women in obstetrics also, the obstetricians also. It is really taxing for everybody to handle, to monitor, and to give, reduce the morbidity also by giving good antenatal care, even postpartum care, in intrapartum and postpartum care also is very important to handle such NCD patients. And it is really critical sometimes for the obstetrician to take care of these patients, and regular antenatal monitoring is important. Also, we have to take care of the physicians and nephrologists. Different people are needed to monitor, to guide, diabetologists, whatnot. So it has become increasing burden on the society on as a whole. And on as an obstetrician, it is really our responsibility to have more updates. So the this webinar is being held in Gujarat. So now we have our esteemed chief guest, Dr. Vinit Sharma sir, Mishra sir here. And really thank you. Welcome, Dr. Vinit Mishra sir. Only on one phone call, he said yes, but I know how busy this person is. Really, he's working hard so much since many years, and he has really given good name in Ahmedabad as a transplant hospital. He's a HOD director of IKDRC ITS Ahmedabad, and also HOD of the Department of Obstetric and Gynecologist. The Institute of Kidney Diseases Research Center, he's the HOD over there, and he works tirelessly for this transplantation work. Underwent training. He has underwent training at University of Pittsburgh Fellowship, USA Seoul National University, South Korea, published n number of articles in peer-reviewed national and international journal, research in the field of stem cell, pelvic hormone prolapse, SUI. He is a specialist in giving great results to such patients of SUI and whatnot. So he is really a person in India who really gives great social service by treating the SUI patients, which is really bothering to all the menopausal, postmenopausal, old age women and female. Also, he specializes in female sexual dysfunction treatments. He was the vice president of FOXI in 2016. So with this brief introduction, may I invite Dr. Vineet Mishra. Sir, please guide us with your pearls of wisdom. Thank you so much for obliging us. With your mere presence, the standard of this webinar has really risen. Thank you so much, sir.
One word from me for Dr. Vineet Mishra, just to add. He is the one of the Foxian who will be the recipient of Padma Shri in future. It's my not only the desire, but we know you will get it. Yes. Thank you so much.
Padma Shri will be honored with your name, sir.
My dear friends, my dear Foxians, we have Varsha. Oh, no one can beat Varsha. Varsha is such a nice, sweet person, and thanks Varsha for such a nice introduction. Then we have Kavita. Wow, Kavita is going to be the next President Foxy. You should take it from me. Very hardworking. First to start something called as education for her campaign. I have known all of them. Now the topic or the series of NCD and pregnancy. We have a unique thing that comes to the institute, that is pregnancy and acute renal failure. Bhagde sir, namaskar. Oh, my friend is there. Yes.
Yes, sir.
Yes. And what we see is, which probably everybody sees very less often, is pregnancy, primary with acute renal failure. Primary with, say, anything between 2 creatinine to 8 creatinine or 14 creatinine. Then first trimester pregnancy and till, almost 28, 29, 30 weeks. Now there is when I entered Kidney Institute in 1990. So these were the patients we started seeing. And there were very paucity of references which were available in the literature. So friends, diabetes and pregnancy, endocrine disorders, other endocrine disorders and pregnancy, all NCDs and pregnancy, which is probably going to be the topic that all the young generation is going to see. And my special thanks to Varsha, and probably my friend Deepak would have guided her, because Deepak Bhai is always there to guide everybody.
Yes, sir.
And he is probably Varsha, Kavita, and all the panelists and all the people who are attending. Probably one of the best soul that is there in Gujarat is Deepak Bhai. Dr. Deepak Bhagde.
Yes, sir.
Yes.
Always supporting.
Yes.
I
Yes.
agree.
Totally non-political. Totally non-political and always ready to help. For him,
Yes, sir.
who is standing, everybody should stand for President Foxy, everybody should stand for everything. But he's always there to help everybody. And he probably has birthday of each and every Foxian and he's always there to wish them. Early in the morning, I always see that, and then I remember, oh, आज वर्षा बहन का birthday hai, Kavita ka birthday hai,
Yes.
you know, and it is Deepak Bhagde who is there to remind everybody. Thank you, Varsha, and
Thank you, sir.
thank you, Kavita, and all the people who are there. And this is going to be one of the best series. I'll be there, but probably I'll mute my video. And all the best. All the best. Again, for Varsha, I'm saying all the best. And Kavita.
Thank you so much, sir.
Kavita, all the
Thank
best.
you.
Thank you so much. Thank you so much. We are blessed to have
So
you.
we all need your blessings. We all need your blessings.
Yeah, it is there.
Thank
It is
you
Yes.
so much.
Yes.
Thank you so much.
Thank you.
Next, Varsha. Thank you for being with us. Varsha, next, yes. I think where is Varsha has gone?
Varsha left. We just read Varsha just. Yeah, she has joined.
Yeah,
Yes, Varsha.
if she's there, I will introduce otherwise. No, yeah. Varsha, unmute and introduce.
Yeah. Now
Yeah.
I was disconnected. Yes,
Yeah.
now our guest of honor, what should I say about Dr. Deepak ji? He is our Bhishmacharya, I will say, of Gujarat, who always guides her, supports her, us, and he is really a very nice, gentle fellow who has tremendous experience, but he doesn't show no ego, only support and encouraging words. So, Dr. Deepak Bagreji, thank you for sparing your time and coming over here. You have just finished your OPD, still you are in the hospital and you have logged in. Thank you so much. Dr. Deepak Bagre sir is the past president of All Gujarat Gynec SOGOG. He's the gold medalist from Ahmedabad. His past positions were head and department of Gynec, MS Shah Medical College, Jamnagar, Scientific Committee Chairperson, Gujarat State Gynecologist President, Jamnagar Gynae Society, President Jamnagar IMA also, Member Board of Studies, Saurashtra University. First ever SOGOG oration was given by Dr. Deepak ji in 2014, and he has moreover delivered 62,000 babies in private practice since 1985. Tremendous, so many of deliveries. Sir, आपके लिए आपकी वजह से इंडिया का नंबर 1 हो गया पॉपुलेशन. Okay, thank you, sir. Thank you for coming over here, and please give some guidance to us and address.
So before that, I'll just like to add, you are
Yes.
Dr. Bagde is a family. I don't have words for it. You are a family. So when we talk about family, say that he's a family, means he's there always and all the time. Love you, sir. Love you.
Varsha, Kavita, you are making my eyes moist.
Okay.
But no, let me tell you frankly.
दीपक जी जरा जोर से बात कीजिए. Cannot hear you.
Okay, is it now? Am I audible now?
Yes, sir. Yes.
Yeah, now you are audible.
Okay. The main thing is, you are amongst the friends.
Correct.
Varsha, you are a lovely friend with Kavita and others, Kanchan.
Yes, ma'am.
And my Gujarat colleagues, Forum, Munjal, Chandni, Vishal, everyone is there, Riddhi is there. It's such a beautiful evening, and Varsha, you did wonders in your chairpersons. Kavita, what I say is less because whatever I say is going to be for a friend. Varsha for a friend. Vinith, being a friend, I'm sure he was going to say something more than what I deserved. But yes, we have worked together, we have liked each other, and main thing, this interesting topics for today, they are going to be really lovely. Diabetes is rampant, yes. And obesity is another thing what we should be discussing about. Renal disease, fortunately, we don't have that many, but the speakers today, I'm sure, are going to do wonders to the topics allotted to them. Varsha, Kavita, even I think Bharti is here, Bharti Rajsekar is here. All the best for your campaign. Is there anyone else who is participating in a Fox election?
Kanchan is there.
Yeah. Kanchan hai, Bharti hai, Bharti Rajsekar from
Thanks a
Bijapur.
lot. for your
Bharti,
blessings always.
Bharti, yes, last week also we
Sir,
are
they are
together.
very loving and always blessings. Sir. Thank you so much. Thank you so much.
So, all the best to you. You have been working hard and
Thank you,
you
Dr.
always,
Deepak, sir.
unfortunately, all of us cannot win, but I'm sure you are all pure Foxians and going to work for Foxy all the time. All the best to
Thank you.
everything. Varsha,
Thank you
thanks
very
again.
much, sir.
Kavita, the speaker is yours. Bye-bye. Thank you. And I'm
Thank you, sir.
Thank you, sir. Thank you so much.
Thank you very much, sir.
Over
Thank
to you,
you.
Riddhi.
Yes, ma'am. It is my privilege to chair this session, and I welcome Dr. Munjal Pandya, sir. Sir is an associate professor working at Narendra Modi Medical College. Sir is a dynamic individual having a plethora of interests. Sir has authored many papers and publications and has also co-edited a book on male infertility. He has received many awards and has also been the past president of Ahmedabad Society of Obs and Gynae. Over to you, sir.
Thank you so much. Thank you so much, Varsha madam, for the opportunity. And my topic is gestational diabetes mellitus. I'll try to cover it up in given 20 minutes. If I do exceed the time
Yes.
limit, just let me know. Thank you. So basically, it is very known complication, rather pathology, which is accompanying pregnancies nowadays more, and more so ever in our developing country, we are facing this challenging. Basically, gestational diabetes mellitus is something that is glucose intolerance of any degree with onset or first recognition during pregnancy. Basically, it is associated with reduction in pancreatic beta cell mass of approximately 67% or more. The prevalence is 3 to 10%. And as FIGO says, that 1 in 6 deliveries or pregnant ladies would have diabetes now all over the globe. If you can divide it into two groups, one is pre-existing diabetes that is already there before pregnancy, which can be divided in type 1, that is insulin dependent, and type 2, which is non-insulin dependent. And the other one is gestational diabetes mellitus, which again can be divided in one, first time diagnosed or pre-existing diabetes, and second one in later pregnancy diagnosed, that is true gestational diabetes mellitus. So the diabetes mellitus, which was already present before pregnancy, basically it is a known diabetes, and all the parameters of non-pregnant state diabetic state would be applied here. So when it comes to hyperglycemia, diagnosed in first time pregnancy, the criteria would be fasting more than 126 milligram per deciliter, 2 or 75 milligram oral glucose tolerance taste more than 200, random blood sugar more than 200, and HbA1c more than 6.5%. Now we know that HbA1c is something which reflects the glycemic control of last 3 months. So more likely when hyperglycemia is detected first time in early pregnancy or before 20 weeks of gestation. Type 1 is autoimmune kind of thing, which would lead to pancreatic beta cell destruction. And type 2 will be lifestyle diabetes or maturity onset diabetes mellitus. When it comes to gestational diabetes mellitus, it is basically hyperglycemia that does not amount to the overdiabetes diagnosed for the first time during pregnancy and may occur anytime during pregnancy, but most likely after 24 weeks. So GDM is basically of two types, type A1 and type A2. Type A1 is having abnormal OGTT, but normal fasting and postprandial levels, and diet modification will be enough. While type 2 is basically abnormal OGTT along with abnormal sugar levels, that is like fasting as well as postprandial. And additional medications would be required along with the nutritional or medical nutritional therapy. So the risk factors for GDM will be previous delivery of stillborn baby, anomalous baby, LGA baby, GDM in previous pregnancy, BMI more than 27 before pregnancy, age more than 35 years, diabetes in one of the first degree relatives, majorly on the maternal side, recurrent UTI or fungal infections, which would again indicate more sugar level of the local part, excessive weight gain, and polyhydramnios with unknown cause. Pathophysiology or pathogenesis is exactly not known, but main feature is insulin resistance. Now, basically, we require insulin for absorption of glucose into the cells. And pregnancy hormones will actually interfere with the action of insulin by binding the insulin receptors. And that is why the insulin will be accumulated more. And that's why there will be more sugar level accumulated in the bloodstream, leading to diabetes. So we know that the glucose will cross the placenta. Insulin will never cross the placenta. But that crossing of glucose into the fetal circulation will lead to more secretion of fetal insulin. And as we know, the growth factor for fetal development would be insulin or insulin-like growth factor. And that is the reason that this fetus or newborn will be macrosomic or large baby. So as we know, the glucose metabolism in brief. Basically, it is fasting hypoglycemic status and postprandial hyperglycemia associated majorly with insulin resistance. So in fasting state, there will be accelerated starvation, maternal hypoglycemia, hypoinsulinemia, hyperlipidemia, and hyperketonemia. While in postprandial phase, there will be hyperglycemia, hyperinsulinemia, hyperlipidemia, and reduced tissue sensitivity to insulin. So we can see in the middle that insulin resistance will lead to more hyperinsulinemias, which would lead to accumulation of fat, and amino acids and glucose will contribute towards the growth of fetus, again contributing to macrosomic fetus. So basically, the factors, pregnancy we know is diabetogenic state. The factors responsible for reduced insulin sensitivity are increased insulin resistance and degradation of insulin. These two are the factors which would lead to more insulin secretion, and that is why fasting hypoglycemia and postprandial hyperglycemia. I'm just enumerating the complications. The maternal complications during pregnancy are diabetic ketoacidosis, deterioration of diabetic retinopathy, diabetic nephropathy, and hypoglycemia when the insulin dosage is not properly adjusted. Along with that, there will be more chances of miscarriage, premature birth, pregnancy-induced hypertension, or now we know that hypertension, hypertensive disorders of pregnancy, polyhydramnios, and maternal distress. During labor, as there will be accumulation of more of fat in the subscapular and shoulder region, there will be more chances of shoulder dystocia, perineal injuries, postpartum hemorrhage, because the uterus will be more of atonic due to over distension. Operative vaginal delivery is more in these cases. And during puerperium, there will be puerperal sepsis, more chances, and lactational failure. So we know this hypothesis, Patterson or Frankel hypothesis, when the mother is having low insulin leading to more glucose, amino acid, and lipid, all three components will cross the placenta, will lead to macrosomia because of more fetal hyperinsulinemia. Later on in neonate, it might lead to hypoglycemia. So this babies immediately after birth will need the glucose monitoring or level of glucose monitoring for next 24 to 48 hours on regular basis. And during childhood, there are more chances of developing obesity and impaired glucose tolerance, leading to maturity onset diabetes mellitus. So when it comes to miscarriage, the rate of miscarriage in diabetic mothers where there is no euglycemic control is 9 to 14%. So as we know, the HbA1c in the bar chart on the last column would show that more than 9.5 would have at least 40% of females getting miscarriage. So HbA1c level and euglycemic level status are essential for optimal pregnancy outcome. Growth restriction, type 1 diabetes would have IUGR, that is intrauterine growth restriction, and type 2 and 1 both will be having more chances of large baby. In case of growth restriction, underlying maternal vascular disease is at fault, and at-risk patients are those associated with diabetes having retinopathy or even nephropathy and with chronic hypertension. When it comes to macrosomia, it is defined as birth weight more than 90th percentile or weight more than 4 kg, seen in 15 to 45% of babies due to diabetic women, threefold rise from normal glycemic controls. Maternal obesity has a strong and independent effect, and birth weight is also influenced by gestational age at delivery, maternal pre-pregnancy BMI, maternal height, pregnancy weight gain, presence of hypertension, and cigarette smoking. Central deposition of subcutaneous fat will be there in abdominal and intrascapular areas. Skeletal growth will not be affected. Shoulder and abdominal girth will be augmented, and that is why it would increase chances of Erb's palsy. And birth injury, including shoulder dystocia and brachial plexus trauma, are more common in diabetic mothers, and macrosomic fetus are at highest risk. When it comes to effect of non-euglycemic status on development of embryo or fetus is like this. In the initial part, if the pre-existing diabetes is having no more glycemic control, the organogenesis will be hampered along with the behavioral changes and then anthropometric and metabolic changes. While in case of GDM, the damage will be in the later half of pregnancy, while teratogenicity will no longer be a threat. And that is why sugar monitoring in the very first visit of pregnancy is very, very essential. Diabetic fetopathy prevalence is around 4 to 8%, again, mainly related to non-euglycemic status. Systems involved are nervous system, cardiovascular system, skeletal growth, genitourinary, and gastrointestinal tract. Etiopathogenesis is said to be activation of hexosaminase pathway in response to maternal hyperglycemia or hypoxia, which leads to accelerated oxidative stress in fetus leading to derangements in the multiple levels ranging from gene expression to apoptosis and organ formation. And there are several other theories. USG markers which would indicate the probability of fetopathy are reduced head circumference or abdominal circumference ratio. Neck thickening will be there. Thickening of head and abdominal subcutaneous tissue along with the cardiomegaly would suggest probability of diabetic fetopathy. Phenotypic signs will be increased scapular width along with increased thickness of neck and abdominal subcutaneous tissue. And visceral signs will be fetal hepatomegaly, cardiomegaly, cardiomyopathy, and pancreatic enlargement. Congenital malformations, HbA1c will be less than 8. If HbA1c is less than 8.5%, anomaly rate is just 3 to 4%. But if the HbA1c level is more than 8.5%, anomaly rate shoots to 22 to 23%. And that is the highest significant value that we know, that 8.5% is the threshold or the marking or the line which must not be crossed during pregnancy or even before pregnancy. Caudal regression syndrome is pathognomonic and is approximately 256 times more than the controls. Holoprosencephaly, neural tube defects like spina bifida, hydrocephalus, CNS defects are twice more common. Congenital heart defects are 2 to 3 times more. And other defects like hallucil polydactyly, anorectal atresia, heterotaxy, and thymus hypoplasia, along with the multicystic dysplastic kidneys, are more common in diabetic mothers. Early neonatal complications are seen in form of hyperbilirubinemia, transient hypoglycemia, polycythemia, respiratory distress syndrome, cardiac complications are common. Pulmonary maturity will lag behind approximately 3 to 4 weeks as compared to the euglycemic patients. And pancreas will show islet cells hyperplasia, which will return to normal within first few days in neonatal period. Preconceptional prevention can be done by having euglycemic control as well. Occurrence of congenital malformation usually starts before 7 weeks of gestation, as we saw in the previous graph. It was said that incidence of congenital malformation was just 0.8% in patient with proper glycemic control, while it is 7.5% in patients with strict metabolic control achieved after 8 weeks. So if it is before 8 weeks, congenital malformation rate is just 0.8%. But if that euglycemic status is achieved after 8 weeks and was not present before 8 weeks, it rises to 7.5%. Pre-pregnancy counseling has to be done in form of diet, exercise, and maintaining euglycemic status. Childhood obesity is common in those babies developed out of diabetic mothers. They would have relatively more fat. While in childhood metabolic syndrome, we know the Barker's hypothesis. By the age of 10 to 16 years, they will be having more of IGT, that is impaired glucose tolerance. And literature supports relationship between intrauterine exposure to maternal hyperglycemia and risk of childhood obesity and metabolic syndrome in later life. When it comes to laboratory evaluation, we know all the routine investigation. Just to focus or highlight upon specific ones. HbA1c, if results are not available within past 3 months. If not performed or available in past 1 year, we can go for fasting lipid profile, liver function test, spot urinary albumin to creatinine ratio, serum creatinine and GFR, thyroid stimulating hormone in patients with type 1 diabetes mellitus. So what would the government of India say? It says for diagnosis of management of GDM patients that universal testing of all pregnant females with single step, that is 75 gram glucose in fasting or non-fasting state, has to be done in very first antenatal visits. So what are the requirements? The equipments required are glucose pouches, 75 gram, 1 per test, measuring flask, drinking water 300 ml, disposable glasses and stirrers. For sugar testing, there will be glucometer with calibration, then sterile lancet, which must not be reused even in the peripheral setting. Cotton, water swab or wipes, but not the alcohol swab. Why? We would know in the later slides. Yellow, red, and black dustbins for discarding the waste, and puncture-proof container. And recording or register has to be maintained for all the patients. So national guideline in 2018 would suggest that testing of GDM is recommended twice during ANC. The first as early as possible, and the second one between 24 to 28 weeks. It is important to ensure second test as many pregnant women develop blood glucose intolerance during this period. And only 1/3 of GDM positive women are detected during first trimester. So the second testing is mandatory and very, very essential. So the puncture has to be done between third or fourth finger. Why? Because these fingers would be having sufficient depth. If you puncture the thumb, it will be pulsar type. If you puncture the index finger, it is more calloused and sensitive. And if you go for fifth finger, it would not have sufficient tissue and would injure or have the pain in bone. Again, wiping with the alcohol is not recommended because many research papers would suggest that alcohol would interfere with the reading of blood glucose, and validation of glucometer is of utmost importance. So what is single taste or dipsy taste? We know now dipsy taste for last many years, like over the 6 to 7 years. So 75 grams of glucose is orally administered in 300 ml of water in over the period of 5 minutes. Blood testing is done with the help of glucometer. After 2 hours, the pregnant lady should rest in this 2 hours and should not eat anything else. If she vomits within 30 minutes, then taste is cancelled and should be repeated next week. If she vomits after 30 minutes, taste is continued and measurement has to be done as routine. The advantages of single test are no need for a state of fasting, can be performed anytime, and no need of repeat visit. Blood sugar more than or equal to 200 will be diabetes mellitus, 140 to 199 will be GDM, 120 to 139 will be gestational glucose intolerance, and less than 120 will be normal. Then what is pre-diabetes? It is impaired fasting glucose with fasting plasma level 100 to 126. Impaired glucose tolerance is defined as 2-hour glucose taste more than or equal to 140 but less than 200, and associated with metabolic syndrome, which is obesity, dyslipidemia of high triglycerides and or low HDL type along with hypertension. Glucose monitoring, blood testing and urine analysis of glucose and ketone bodies and HbA1c are to be done. Fasting blood glucose is predictive of neonatal fetal mass and subsequent development of childhood obesity and diabetes. 1 hour postprandial glucose level predictive of blood sugar level control and subsequent development of LGA fetus and more chances of cesarean section. After stabilization of blood sugar, individualization of frequency of sugar measurement, adherence of the patient to treatment, and need for further management is recommended. Just to sum it up, HbA1c is basically glycosylation of hemoglobin. Advantage is it is single test, non-fluctuating, and reflecting the sugar level over past 4 to 8 weeks. Should be done in the first antenatal evaluation. We know the level 8.5%. It also increases in cases of non-hemolytic anemia and chronic renal failure. And ideally, if the HbA1c is around 10 to 12%, up to 25% fetus would be having major congenital malformations. So to sum it up, the testing part, it is basically universal testing of all pregnant females. In community, the first testing as early as possible. And basically, if we go for DIPSY, one test, 75 gram glucose in 300 ml, 2-hour postprandial level has to be measured. If it is 140 or more, manage as GDM. If it is less than 140, repeat at 24 to 28 weeks. If it is positive, again GDM. If it is negative, manage as normal ANC. Recommendations, just the levels I would highlight that fasting more than 120 is 126 is over diabetes, treat and follow up as pre-existing diabetes. Fasting plasma more than 92 but less than 126, 75 gram OGTT. Fasting plasma less than 92 and test for GDM at 24 to 28 weeks because we might miss many of the GDM cases or not develop GDM at the first trimester. So the last but the most important part, again, one of the most essential parts of the pregnancy is fetal monitoring. Just to sum it up, 3 slides. Periodic biophysical profile has to be done. Fetal heart rate monitoring has to be done. Fetal movement assessment, USG with biophysical scoring, fetal umbilical Doppler as early as 28 weeks. Low risk patients, formal testing can be started at around 34 weeks. And fetal movement counting in all pregnancies, 28 weeks onwards has to be done in those diabetic mothers. Imaging studies, first trimester we know as dating scan, knuckle translucency is important. In second trimester, anomaly scan, fetal echo if HbA1c is elevated and if the mother is having any congenital heart defects. In third trimester, growth scan every 4 to 6 weeks from 26 weeks onwards. In overt pre-existing diabetes, only 22% of fetus is diagnosed as LGA by USG, had macrosomia after birth. Assessment of fetal growth, it is like accuracy of fetal growth monitoring is only within 15%. Significant error existed between degree of error in USG based fetal weight estimation and percentage of body weight on fetus or body fat on fetus. And accelerated growth of AC begins to rise significantly above normal after 24 weeks. So these are the findings we need to keep in mind while doing fetal ultrasonography. So this is all I had for GDM. Thank you so much.
Great lecture, sir. Each and every detail is covered in within 20 minutes. It's like everyone knows the malformations associated with GDM, but sir has also covered the pathogenesis and the cause behind it. Going to be very useful in routine day-to-day practice. Thank you, sir.
Thank you. Thank you so much.
What a talk, really the crisp one and the smart one. Ekdam. My voice is not coming. Very, very crisp and smart. Very crisp and smart.
Thank you. Thank you, ma'am.
Manjul
Thank you.
Pandya, you gave such a elaborate, exhaustive, point-to-point diagnosis like lecture. It is really means really thankful for you to give such a nice
Thank you.
presentation, and we witnessed your efforts, how much you have put in that
Thank you.
preparing that presentation. Thank you so much. We are really
Thank you.
glad for having you here.
मेरा एक
Thank you
छोटा सा
so
point
much for
है.
delivering such a fantastic lecture.
Varsha,
Over to you.
I have just one point because of it. The thing is that India is going to need this all the tests and everything at the rural and unprivileged area also, because diabetes is going to make havoc in the NCDs in the future. So I think the way you presented it was really simple. I'm really honest that I hardly hear many of us. But I'm so happy that I was here and I listened to you. So
Thank you. Thank you so much.
It was. Yeah.
I will need to read it, reread it to understand it completely. Really, thank you.
Thank you, ma'am. Thank
Over
you so
to
much.
you, Dr. Riddhi, and unmute Dr. Riddhi.
Dr. Forum.
Dr. Riddhi, unmute yourself. Can't hear you.
Varsha, you
Am
invite
I
Forum.
audible, ma'am?
Okay.
Yes.
Okay, I will take over. The next topic is by Dr. Kavita Bapat, and may I invite the chairpersons, Dr. Forum Acharya, first one, who is the obstetrician and gynecologist from Ahmedabad medical, and she is fellowship in medicine, fetal medicine from Paras Advanced Center of Fetal Medicine, Ahmedabad, fellowship in advanced ultrasound also in OBGYN from Gujarat University, and special interest is fetal medicine and fetal treatment. So may I present you Dr. Forum Acharya. The next chairperson is none other than Dr. Chandani Mehta, the beautiful assistant professor of Vijay Medical College, Ahmedabad, and she is there to assess the talk of Dr. Kavita Bapat. Dr. Forum Acharya, please introduce Dr. Kavita Bapat, and Dr. You do you give the closing remarks after her talk.
Yes, ma'am. Good evening, everybody. I would be honored to introduce Dr. Kavita, ma'am, who is a very eminent name in minimal invasive surgeries in India and one of the pioneers in laparoscopic surgeries. She has been the vice president of FOXY 21-22 and a director at Bapat Hospital, Indore, and a FOXY presidential candidate. All the best for the elections, madam. Over to you.
Thank you so much, Beta. Allow me to share the screen, and Nishant, please allow me to record this lecture. Are you there, Nishant?
Yes, ma'am.
Yes,
One
yes.
second.
Are you there?
It will be recorded and it will be given in the circulated also.
I do it myself, so he'll allow me to do. Yeah. Thank you so much. Thank you so much. Thank you so much. So, Varsha, thank you so much for this arranging this webinar in for the all Gujarat. Which this isn't really good, and you have given me the topic storm hyperthyroidism. You are making me study so many subjects. Thanks, Varsha, once again. Such a great friend of mine and lot of this. And such a beautiful chairpersons I have too. Very good. The forum.
Yes.
And another one.
Chandani.
Chandani. So sweet of you. Thank you so much. And nice content. You are being there still.
Thank you.
Thank you so much. So the topic.
Let me tell the audience also that we are live on YouTube also. So it is recorded there also, Dr. Kavita Bapat. Over to you.
Okay. So it's just a glorious journey begins with a bright vision. I always say, and I come from a place in the storm hyperthyroidism in the pregnancy is another big subject. Though I haven't seen much cases all over my life of this type of subject, but if this type of patient comes to you, we should know. And this is another big thing. So I'm just discussing one case, we'll talk about, and we'll talk about the things. And it's an interactive one, we can make it and talk about. So it's a 28 years old, gestational age 32 weeks, gravida 2, para 1. Medical history, hyperthyroidism treated with a methimazole 10 milligram twice a day before pregnancy. Obstetric history, uncomplicated vaginal delivery at term in first pregnancy, and no history of preterm labor, miscarriage, or the stillbirth. Then the presenting complaints, the patient presents 3 days history of fever, sweating, palpitations, and shortness of breath. She reports feeling anxious and restlessness is increased irritability and insomnia. She also reports the loss of appetite and a weight loss. Then on clinical examination, vital signs, temperature 38.5, pulse rate 120, blood pressure 110, respiratory rate 18 breaths per minute. Oxygen saturation 98% on room air. General appearance, patient appears anxious, agitated with the tremors in the hand. Cardiovascular, tachycardia, regular rhythm, no murmurs, rubs or gallops detected. Respiratory system, the lung fields are clear on auscultation. And these are the gastrointestinal system also we have found out. The abdomen is soft, non-tender, no hepatosplenomegaly. The pregnancy is there. Neurological symptoms, no focal neurological deficit noted. Then investigations done, the thyroid functions test done. Thyroid TSH less than 0.1, normal range is 0.27 to 42. Free T4 more than 50, complete blood count normal, electrocardiogram sinus tachycardia with a heart rate of 120 beats per minute. No ST changes or arrhythmias detected. Chest X-ray came normal. And the diagnosis of this type of based on the clinical presentation and the laboratory investigation, as well as we had a great history. So to find it out, the diagnosed with the storm hyperthyroidism in pregnancy. Now, how she was managed as a case, the patient was admitted in the hospital, managed with the following measures. Number 1, methimazole is discontinued due to the risk of fetal hypothyroidism. So it was discontinued before. Propylthiouracil PTU 200 milligram orally every 6 hours is initiated. It is safer in a pregnancy and can be used in a third trimester also. Propranolol 40 milligram orally every 6 hours initiated to control the tachycardia and other symptoms. Patient kept under the close monitoring for any signs of fetal distress or a preterm labor, and consultation of the endocrinologist and obstetrician is obtained for the further management. Now, the outcome of this patient, the patient's symptom gradually improve, her vital signs stabilize, thyroid function test improvement, TSH increasing, free testosterone T4 is decreasing. The patient remains under the close observation, discharged home with a close follow-up. She is advised to continue PTU until delivery and to plan elective delivery at term, because we cannot leave this type of patient. So it was planned that she should deliver electively, and there is a regenerative response. So we are talking today about the thyroid storm or the thyroid toxic crisis. Now it's a medical emergency. It's characterized by the severe acute exacerbation of the signs and symptoms of hyperthyroidism. Very, very rare complication and occurring approximately 1% of the pregnant patients with hyperthyroidism. For my knowledge, a practicing person last 32, 33 years, I'm extremely happy, or I can say I'm extremely sorry to say that I have never seen a patient of hyperthyroidism in pregnancy during my practice. And probably I have not missed it also, because I can assure myself that I have not done that mistake. And it is significant maternal and perinatal mortality and morbidity. And a vast majority of the women presenting with the thyroid storm have a history of hyperthyroidism. So make it a point very, very clear. If the patient is having the history of hyperthyroidism, because during pregnancy, the hyperthyroidism initially gets normal and then again the problem starts. So we are worried about that there is a history of hyperthyroidism we should be worried about. Now, in the most common cases, there is a Graves' disease. It accounts for the 95% of all cases of hyperthyroidism in pregnancy, and it's caused by the circulation of thyroid-stimulating autoantibodies. There is ophthalmology, exophthalmos, lid lag, and lid retraction is there, and dermopathy is that there is a peritibial edema and a clinical signs are specific of the Graves' disease. So hyperthyroidism, because of the Graves' disease, these two things are very, very important: ophthalmological changes as well as the dermopathy. Hyperthyroidism refers to the clinical state resulting from the excess production of thyroid hormones. So that's another most important point about it. Then the point comes, other causes of hyperthyroidism. We'll say why it happens. Number one is the toxic multinodular goiter can be there. They include the inflammation, that is the thyroiditis. There is a solitary toxic thyroid nodule can lead to hyperthyroidism. Hyperemesis gravidorum or gestational trophoblastic neoplasia can stimulate the thyroid hyperthyroidism and lead to hyperthyroidism also, and the ingestion of exogenous thyroid hormone. And TSH secreting pituitary adenoma is one of the cause for the hyperthyroidism in the pregnancy. Then, in order to minimize the complication, including thyroid storm, hyperthyroidism is best diagnosed and treated prior to pregnancy. So, any patient who is having the history of hyperthyroidism, they should be pre-planned, pre-antenatal checkups should be there. She should be planned, she should be treated. All the levels should be normal, and then she should plan a pregnancy. An inciting event such as infection, hypoglycemia, like a diabetes he was talking about, venous thromboembolism, or any surgery or anything like a labor or delivery, they can be identified in many instances of the thyroid storm. So, for example, if the patient is always having the history of hyperthyroidism before the pregnancy, and that patient becomes pregnant, and if she gets some infection, some hypoglycemia, all these things, she can end up into the thyroid storm. So clinically, how we'll say that this is the thyroid storm is diagnosed by the combination of symptoms and sign with the thyrotoxicosis include tachycardia, which is out of proportion. Fever is there, but the most important is the tachycardia, and that is more than 140, 160. Fever is also there. Altered mental status in many patients, like a restlessness, nervousness, confusion, seizures in few of the patients. Diarrhea is a different symptom. Sometimes we don't understand why she's having so much diarrhea. Vomiting, we have to differentiate it with the hyperemesis gravidorum also, because with hyperemesis gravidorum, there is no diarrhea, no tachycardia, no fever, until and unless the untreated hyperemesis gravidorum can lead to both of the things. Cardiac arrhythmias are also there. So clinically diagnosed can be difficult to make clinically if thyroid storm is suspected. Serum thyroid function should be sent immediately. Biochemical findings supportive of the diagnosis include there is a suppressed level of thyroid binding globulin. Already we all talked about there is a raised level of T3 and T4 and a less level of TSH is there. But this is another thing which we should get it done. That is a thyroid binding globulin. This is a suppressed level. There is increased free levothyroxine. Then increased L-triiothyroxine, the like T4 and T3 are there. Although the most women of the Graves' disease will have a circulating anti-TSH receptor, anti-microsomal receptors, anti-thyroid peroxidase and autoantibodies, and measurement of such antibodies is neither required nor recommended to establish the diagnosis. So hypothyroidism in a pregnancy we can diagnose simply by TSH and T3 and T4 levels, and sometimes the binding globulin is necessary. Moreover, the antibody levels do not correlate well. Either it's a maternal or a perinatal outcome. So if you will find the big antibody level are there and still the maternal and perinatal outcome, it's not comparable. So very important. Now, how to differential diagnosis to be made when we talk about hyperthyroidism or the storm is there. So they mimic the similar symptoms in a clinical. Number one is the sepsis. Patient having a fever, tachycardia, altered mental status, common symptoms like a thyroid storm, acute myocardial infarction, which is also very rare. Again, they are having a chest pain, dyspnea, tachycardia, which can be mistaken for the symptoms of the thyroid storm. Pulmonary embolism. We have to differentiate the pulmonary embolism because they can also come with a tachycardia, dyspnea, chest pain are the common symptoms. Then hypertensive crisis. This is another because the BP with the blood pressure, gestational hypertension is there or HDPs are there. Crisis can present with a headache, nausea, vomiting, altered mental status, which can mimic the symptom of thyroid storm. Drug toxicity. Sometimes salicylate toxicity can fever, tachycardia, mental status and everything. Same with the adrenal crisis. They can complain with abdominal pain, nausea, vomiting, mental status is altered, and they also mimic like a thyroid storm. Then the psychiatric disorders. See, the psychiatric disorders is going to be a very big entity in a future, and we should be very careful about it. Again, the anxiety, panic attacks, tachycardia, palpitations, sweating, they can be mistaken. And diagnosis of the thyroid trauma require, number one, good clinical evaluation. Number two, a very good laboratory investigations. And third, we have to correlate with everything and we have to rule out the potential causes. And there is a regenerate response also. Now, what should be the goals when we talk about the treatment of the thyroid stem cell? Number one, either we reduce the synthesis and release of the hormones from the thyroid gland. So how can we do it? By using thioamides such as PTU or the methimazole. Then we can supplement the iodine. Then sometimes we have to use the glucocorticoids. This is the one thing, either we reduce the synthesis or we have to block the peripheral action of TSH. Well, how can we do it? By glucocorticoids, by PTU and beta blockers. So there is a one difference between the two, because the glucocorticoids and PTU being used for the everything, but the beta blockers, if we want to block the action of the peripheral action of the TSH. So another goal of the treatment is how to treat the complication. Number one is we need a physiological function should be supported. We should be managed this type of patient in an ICU. Acetaminophen, cooling blankets, supplement of the oxygen, fluid and a caloric replacement. These are the identify and treat the participating events, because they can be having the precipitating events like a hypoglycemia may be there. There may be a thromboembolic event or the diabetic ketoacidosis, and these patients can end up into thyroid storm. So we are supposed to correlate between all of them. Again, we have the acute maternal illness or the fetal well-being is very, very important. That is the third part of the management or the goal of the treatment is, and it should be appropriately evaluated and consideration is given to the delivery if appropriate. Fetal tachycardia is another point, is a sensitive index of the fetal hyperthyroidism. So make it a point if in a pregnant patient, if she is having the fetal tachycardia also, which is more than 160 beats, it's an index of suspicion that the patient's baby or the fetus can have a hyperthyroidism in future. Only 1 to 5% of the neonates born to women with a poorly controlled thyrotoxic develop the transient hyperthyroidism or the Graves' disease caused by the transplacental passage of maternal antithyroid antibodies. So its number is very less, and the role of antithyroid antibodies is not much into this thing. So again, how are the other goals are? One, the patient is stable. It is important to follow the serum electrolytes, especially potassium. ABG is also very, very important, arterial blood gas, that is 2 to 4 hours, because if the patient is not hemodynamically not stable and we have to admit her into ICU, so all these things are there. Then catheterize the patient if conscious and not passing urine. Decompress the stomach if unconscious, and to continue the fetal surveillance, and the woman will fail to respond. The initial medical therapy options are very, very limited. Radioactive iodine administration to ablate the thyroid gland, absolutely contraindicated with pregnancy, but sometimes or rarely it has to be done, and it can permanently damage the fetal thyroid. Surgery is best avoided, but may be required sometime. Now, what are the treatment? Again, this is a similar of the goal of the treatment, but we are worried about many more things. General guidelines are, number one is the supportive care. That is significant stress of the body, and supportive care is very, very important. That includes oxygen, intravenous fluid, and electrolyte replacement. Then antithyroid medication, first line treatment is such as PTU and methimazole. These medication block the production of the hormones. This is a repetition of this thing, but I'm telling you. Then control the hyperthyroidism. P2 is preferred in a thyroid storm. Due to the additional effect of inhibiting peripheral conversion of T4 to T3, we are needed. Then beta blockers, why it is needed? Symptom of hyperthyroidism, tachycardia, palpitation, and tremors can be treated. Propranolol is a preferred agent in addition to elicit the inhibiting peripheral conversion T4 to T3. Then glucocorticoids. Glucocorticoids in some cases it is important. It reduces the thyroid hormone production and release and help to suppress the autoimmune response in the Graves' disease. Dexamethasone is a preferred agent due to its lower mineralocorticoid effect. Then the cooling measure is very, very important. High fever is there. Cooling measures such as ice packs, cooling blankets, a fan, reduce the body temperature. For the management of complication, we need for the arrhythmias, heart failure, heart dysfunction, a very good ICU setup is very, very important, and it should be management. It should be done into the intensive care units. So what are the definitive treatment? Once the patient is stable, definitive treatment is surgery or the radioactive. After the delivery, it can be done if there is a thing. And the treatment of thyroid storm requires a multidisciplinary approach, endocrinologists, critical care specialists, and other health professionals. And the goal is to control hyperthyroidism and manage complications. This I love to talk about whenever I finish my talk is the algorithm. Number one, confirm the diagnosis. Identify the women at the risk of thyroid storm. Perform a detailed history with a physical examination. Check thyroid tests. Unable to confirm the diagnosis, consider other diagnosis, confirm gestational age, document fetal well-being, and manage as an outpatient continued strict control of hyperthyroidism. If we are able to diagnose the thyroid storm is confirmed, admit immediately, confirm the gestational age, document well-being, exclude infection, thyroid storm, consider by checking cultures, urine culture, X-ray checks. Institute treatment immediately, manage with ICU setting, that is every 15 minutes maternal vital signs, EKG, face mask oxygenation, supplementation is 4 to 6 per liter per minute, and continuous fetal monitoring if the baby is more than 24 weeks. Now, initial antithyroid drug is a propionate, this is PTU, this is 600 to 800 daily, a stat, and then 150 to 200 orally for 6 to 8 hours. And the saturated solution of the potassium iodide, it should be also administered. An alternative source of iodine, like a sodium iodide or the Lugol's solution, or the lithium carbonate can be given. Dexamethasone, 2 milligram IV every 6 hourly for 4 days. Propranolol for the beta blocker, 20 to 80 milligram orally, 4 to 6 hours, or the 1 to 2 milligram IV in every 5 minutes should be done. The phenobarbital is 30 to 60 milligram orally and need as an extreme restlessness. One, the patient is stable, continuous and close observation, plan the delivery and do it in a different manner. Thank you so much for this today's webinar that all those who have attended. And I am really blessed to be a part of this, and thyroid storm. I like the subject always. Thank you so much.
Thank you so much, ma'am, for sharing your invaluable knowledge and insights on hyperthyroid storm in pregnancy. This was a very quick, informative, and practical session. Thank you so much, ma'am.
Thank you so much, Anil. Thank you so much.
What a talk, what a fantastic talk, and elaborate, detail, everything you have given us like a research paper, Dr. Kavita Bapat. Thank you so much for giving such a wonderful talk and gracing the occasion also to be present over here for the Gujarat webinar. We are really blessed to have you here. Thank you so much.
I'm here till you are moderating the panel. I'm there. Yeah.
Yeah.
Thank you so much.
I welcome Dr. Devang Patel also now.
Cool and
Dr. Riddhi, are you
Yes,
there?
ma'am.
Or
Yes,
I will continue.
Yes, ma'am.
Okay, now I will continue with the final panel discussion of NCD management in pregnancy, which is very, very important. Preconceptional, from counseling to ANC care to intrapartum, postpartum, and whatnot. It is really, really judicious job from the for the obstetrician and for the other diabetologists and other physicians also. So we have our my co-moderator. I am Dr. Varsha Baste, my co-moderator, Dr. Devang Patel, who is the very, very renowned person in Ahmedabad, consultant obstetrician gynecologist at CIMS Hospital, director of Gujarat Fetal Medicine Center and Divine Women Hospital, maternal fetal medicine specialist. And he is the first FNB of Gujarat assistant professor. He was the assistant professor of BJ Medical, Ahmedabad in 2013, fellow of National Board of High Risk Pregnancy and Perinatology in Fernandez Hospital, Hyderabad from 2 years, and for 2 years, fundamental critical care support, SSCI certified, advanced life support in obstetric, AAFP certified, areas of special interest and hypertensive disorders. That we are going to discuss all these medical disorders, apply SLE, jaundice, thrombocytopenia of pregnancy. What more we would like to have such a learned person to be a moderator for our panel discussion, and his interest also in multifetal gestation, fetal echo, amniocentesis, everything about fetal medicine. So I welcome you, Dr. Devang Patel, and let us introduce all the panelists. Can you please introduce all the panelists, Dr. Devang Patel?
First of all, thank you, ma'am, for
I cannot hear you. Please talk loudly.
Okay. Thank you, ma'am. Am I audible now?
No.
No, sir.
Very make it
Voice
loud.
is very low, sir.
Now is it,
Saitya, please help him.
now
Yeah,
is it
he is
okay?
audible.
I welcome all the panelists, esteemed panelists who have been present here, and really wonderful to have you all. Thank you for gracing the occasion and making time out from your busy schedule to be here as panelists.
Am I audible
And
now?
I also welcome Dr. Kanchan Sharma from Kanpur, specially came over as a panelist to attend this webinar.
Thank you, madam.
Am I audible?
Thank you for giving me
Yeah,
chance.
little bit you are at, you can carry on. What can we
Now,
say?
now am I audible?
Please remove the
Dr.
earphones
Devang
and
Patel.
check one, sir. Maybe due to the earphones, it's coming very low. So,
No, now this is not audible. Previously it was audible.
Now,
Yes.
Yes.
yes. So, ma'am, thank you for the kind words, and I'm going to start to introduce my panelists. It's indeed an honor to be a co-moderator with Varsha, ma'am. I would like to invite Dr. Gunjan, who is a renowned gynec in Gandhinagar and Botar. He is a director at Shraddha Women's Hospital. The other co-panelist will be Vishant Patel. He is okay. Dr. Mahesh Jariwala, sir. He is a very experienced senior gynecologist in Ahmedabad, practicing at Femcure Hospital. Then the next panelist will be Dr. Vishant Patel. He is expert in the field of laparoscopy, fertility, and high-risk pregnancy. He is practicing in Himmatnagar, a town near Ahmedabad. The next panelist would be Dr. Dhaval Dharani, who is leading and best gynecologist at Palanpur, and his special area of interest is fetal medicine and high-risk pregnancy. The next panelist would be Dr. Akshay Shah, sir. He is very senior and renowned gynecologist and associate professor at SVB Hospital, who has taught all of us a lot many things. The next panelist would be Dr. Nikhil Anand, sir, who is associate professor at Vadnagar Medical College and getting a lot of referrals in high-risk pregnancy, and a renowned gynecologist. With this, I would like to share my screen and we can start.
Also, we have Dr. Kanchan Sharma from, she is the president of Kanpur OBGYN Society, and her special interest in NCDs. I welcome you, Dr. Kanchan Sharma from
Thank you
Kanpur.
so much. Thank you so much, ma'am.
Yeah, over to you, Dr. Deva. So, can you share your slide PPT, Dr. Deva? Yeah, so the non-communicable disease management in pregnancy, a very vast subject, but let us discuss it as Dr. Devang has put lots of effort in preparing the PPT.
Yes. So, ma'am,
So
would you
these
like
are our
to
esteemed
start
panelists for this panel discussion. We will ask first question to Dr. GB.
Dr. Gunjan.
what are non-communicable diseases and why are they so important? Are you there, doctor? If not, anybody can take it.
Yes, ma'am. Who can
Yeah.
understand and speak? Thank you, first of all, thank you. And all the best and congratulations, Varsha Di and Kavita Di, for making me a part of such a prestigious webinar on non-communicable diseases. And the non-communicable diseases are now very important for all of us. These include hypertension. These are the non-communicable diseases. Hypertension, diabetes, these include anemia, even thyroid disease, these include SLE, psychiatric diseases, obesity even. These all contribute as such non-communicable diseases.
So you are absolutely right. The hypertension, diabetes, anemia, thyroid disorder, SLE, psychiatric disorder, these are all non-communicable disease. There is no infection, but they are metabolic problems and major cause of they are the major cause of indirect maternal deaths also. Morbidity also is increased during pregnancy and after also. So it is really a bad situation of patient having all these NCDs during pregnancy.
And may I interfere? We also include alcoholism and tobacco chewing in non-communicable diseases.
Okay, so let us take the first case. This is the case-based discussion. So she is gravida 3, abortion 2, 34-year-old. First was 8 weeks miscarriage. Second was 6 weeks completed miscarriage. BMI 32. She is a hypertensive 140/100. She is on Telma, that is 40 milligram per day, and she is planning for pregnancy. So my question to Dr. MJ is, can you tell us the classification of hypertensive disorders in pregnancy and what are they? Dr. Visang Patel, you can also take the question. Visang, unmute yourself.
Yes, ma'am.
Yes, ma'am.
Okay. Hello. Am I audible?
Yes.
Okay, thank you for giving me the opportunity, ma'am. So classification of hypertension in pregnancy, it is the primary hypertension or the secondary hypertension. The primary hypertension, which is diagnosed before 20 weeks of pregnancy, we call it as chronic hypertension. BP is more than 140/90 before pregnancy, before 10-20 weeks, and which is the frequency is 1 to 5% of the pregnancy. The gestational hypertension is classified as beyond 20 weeks. Proteinuria is there, but no evidence of eclampsia or preeclampsia. And next comes the eclampsia and preeclampsia. So the primary hypertension and the secondary hypertension. The secondary hypertension is due to renal disorders, renovascular diseases, renal parenchymal diseases, endocrine, Cushing syndrome, pheochromocytoma, coaction of the aorta, or a vasculitis.
Okay.
So I would like Vishank Bhai to continue.
Yes, Dr. Devang, you take over.
Yes. So Dr. Vishank, I would like you to continue and how would you guide this lady before pregnancy? What would you be your approach in pre-pregnancy counseling?
Okay, so the pre-pregnancy, we will first counsel about the possible complication due to the hypertension in the pregnancy. So the pre-pregnancy counseling starts with the medicines, and we will look at the BP charting, and we will prescribe the medicine as soon as she conceives. We will stop the category C or category D drugs, and we will shift over to the Lobate or the drugs which are safe in a pregnancy. Then we will also rule out any pre-existing diseases. We will go for the renal scan. We will go for the endocrine blood test. We will rule out any coarctation of the aorta or vasculitis, and we will also go for a physician reference for cardiac evaluation, 2D echo and ECG. The investigation part is already I have said. We will come to the imaging part. We will go for the renal Doppler. medicine modification is also there. Then the meticulous planning in pregnancy regarding the further treatment will be advised, and as soon as she conceives, we will go for the complete hemogram, we will go for complete renal function test, 24 hours urine protein, we will go for antibody test like antiphospholipid antibody, anticardiolipin antibody, glucose anticoagulant. And as I have already said, the ECG and 2D echo cardiac evaluation by physician is also must.
Excellent. So the main
May I
purpose of
interfere?
evaluating.
May I interfere, sir?
Yes.
Actually, the change of the medicine should not be done after she conceives. The change of medicine is a pre-pregnancy planning, because when the patient comes, we say that if you are on the telmisartan, if you are planning for the pregnancy, you have to change the medicine, because many times the patient comes after first period misses, and the initial cell division that takes place, and that have the effect of the medicine. So this is the pre-pregnancy planning of the change of the medicine. That is my say.
So I agree with you, ma'am. And as rightly said by Dr. Vishant, that the main purpose is to evaluate the secondary causes of hypertension.
Yes.
What next? Termination?
Because she comes with pregnancy UPT positive and she's still on telmisartan. So Dr. Dhaval, if you are present, can you guide us whether you want to terminate or continue? Ma'am, if I just want to interrupt, I want to know how many panelists are there so we can direct the questions. So is Dr. Dhaval there? If yes, then please unmute and say yes.
Devang bhai, can I speak something in between?
Yes, please.
Yes.
Devang bhai, I think that what happened with me as well, and I talked to forum just now, we were opening some other link because there were two links, probably one for the audience and one for the speaker. But by mistake on our side, we have opened the link of the audience instead of the speakers. So like me, other panelists have probably opened up that other link. So if somebody can call them to open the link which is for speakers, they will be visible, because I could make it possible just now.
Haven't you received mails? Mails तो मिले थे ना सबको? Mails नहीं मिले क्या?
Yes, मिले थे madam, but that's what I said. That was a mistake on our part, because there were two links in WhatsApp group. We opened.
Saiti, can you help him?
So if we can take a break of 1 minute and can call the rest of the panelists on phone and ask them to open that other link, it will be workable.
I think that will be better. So I'm muting.
So Saiti, please help him, Doctor.
Meanwhile, sir, you change your name, no? Rename yourself.
You rename yourself. Doctor, rename yourself. Akshay Shah.
Yes, sir.
Okay. So now how to invite other panelists?
Hey, madam, I am calling them.
Okay.
I am calling.
Till then, Dr. Kanchan Sharma, you can
I am calling
talk
Dr. Mahesh
bit.
Jariwala. I am calling Dr. Mahesh Jariwala. If somebody can call Gunjan and somebody can call other panelists. Jariwala sahib, Akshay. Sir,
that's why I was wondering why they are not joined. Okay.
Because I can talk till then, because this is said that telmisartan should not be given in the pregnancy, and that has an effect on early fetal development and can have a teratogenic effect on different limbs of the fetus and etc. So ideally, first of all, patient should be counseled and said that you may have these problems because of this medicine. We have to do the change of the medicine and see the effect of your fetus on your fetus of the particular medicine. For that, as we are doing anti-scan and anomaly scan, they have to be done with the cool-minded and the proper scanning. And naturally, when we change the medicine, we have to control the blood pressure and do the proper BP monitoring with the particular chart that is given to the patient, do it proper charting of the blood pressure with properly sitting position after the rest. That is all which is advised, and also along with this, monitor urine protein. That all has to be done.
I welcome all the panelists over here. Now I can see Dr. Riddhi Bhatt also, Dr. Akshay Shah. Rename yourself, Dr. Devang. Sorry, Vishal there, and also one Nikhil Anand is also joined. Okay, welcome all. Please rename yourself, Doctor. Your name should be seen on the screen. Okay, Devang, let's move.
Received news that Dr. Nikhil has joined, and I think other panelists might also be joining. So, is Dr. Dhaval has joined? Can you just reply?
We cannot see. We cannot. The slides are not moving.
No. I'm just asking.
And we cannot hear you also. Okay, how to manage? Dr. S, can you tell us?
The next one, this has this completed.
Akshay Shah. Do you know the question?
Dr. Akshay sir, please unmute yourself.
Dr. Devang, please show him the previous slide so he will know the question.
Dr. Akshay sir, please unmute yourself.
She's a patient with UPT positive.
Yes,
and
madam.
Blood pressure is 140/100.
Yes.
How will you manage? She's on Tilsma.
Oh, yes.
40 milligrams.
Madam, first of all, we need to change the drug because as Dr. Vishang also stated that we will try to avoid category C and category D drugs. So we will put on safer antihypertensive. That is one. As she is 34 years old and hypertensive, she, as per the FOXY guideline, she is a high risk for development of pregnancy-induced hypertension. So I would like to put her on Ecosprin 150 milligram as well. Of course, we will definitely like to carry out the basic investigations, the hemogram, renal function test, liver function test, cardiogram, and 2D echo. And if I'm not wrong, because the slides are not visible, if I'm not wrong, she has a history of previous 2 abortions, right? Is that right, Devang sir?
Yes.
Yes. So, of course, it is a questionable, but I would like to share my experience. May not be as per the standard guideline. The experts will opine of their, they will have their opinion. I would like to put them on low molecular weight heparin as well, at least up to 12 weeks. And after that, the uterine artery Doppler will let us know whether to continue the heparin, low molecular weight heparin or not. So obviously, we will monitor the pregnancy and maternal system with the help of blood pressures.
Okay. Thank you, Dr. Akshay.
Okay. Can we call it preeclampsia or pregnancy-induced hypertension?
This is early pregnancy.
Dr. Nikhil, he has joined.
Yeah, absolutely.
This is early pregnancy. This cannot be named as pregnancy-induced hypertension or essential. So it is not a pregnancy-induced hypertension. So
Nikhil Anand, can you tell us the diagnosis, this description and frequency of this about this, how to diagnose, how to label if she is a chronic hypertensive, gestational hypertensive, preeclampsia, eclampsia? Dr. Nikhil Anand.
Yeah. Good evening, ma'am. Dr. Nikhil here. First of all, I would like to thank all the speakers and the organizing team for giving me the opportunity. Now, as these are the most important as for obstetrician, hypertension is one of the most important things they have to consider. So, diagnosis of hypertension is the most important factor. So, how to diagnose it? So, we are as we have seen, the hypertension can be classified as a primary or secondary, and secondly, we can classify it also depending on the obstetrics cause. So whether it's a PIH, whether it's a gestational hypertension, or whether it's a preeclampsia. Now coming to the differential diagnosis, we can say that when it is a chronic hypertension generally it presents before the pregnancy. If we are lucky enough, we can see the patient in pre-pregnancy state, and if the pre-pregnancy blood pressure is high, then we can label it as a chronic hypertension. It is generally before pregnancy, or sometimes if it is diagnosed in pregnancy, then it is mostly present in the first booking visit or before 20 weeks. It persists after 42 days also, but it is a retrospective finding. Secondly, if we can find out whether it is a PIH or a gestational hypertension. So to differentiate between PIH and gestational hypertension, PIH and gestational hypertension both generally develops beyond 20 weeks, but in gestational hypertension, the degree of proteinuria is very less. Sometimes it's absent, or if it is present, then it's a +1 only or minimal. While in the preeclampsia, we can say that it is with the hypertension, blood pressure reading more than 140/90, but with the proteinuria. So it is a preeclampsia, or you can find out along with the hypertension, you can find out the other complications of the hypertension, such as fetal effects or maternal effects.
Very
Likewise,
rightly said by Dr. Nikhil,
any.
sir. Very rightly said. Thank you so much. So the main purpose of dividing is because each one has different risk for the mother and fetus. So dividing it will have us guide in monitoring. Now our case proceeds that she was shifted to labetalol 100 mg thrice daily, low dose aspirin. She was not given injectable heparin. And at 26, what we see is her total weight gain is 11 kg, fetal edema, and her blood pressure is still 150/100 millimeter of mercury. So, Dr. Kanchan ma'am, what would you do next when we have a superimposed preeclampsia in this? So what investigations and when to repeat, and how will you go ahead with this?
Yes, actually the purpose of the investigations are, first of all, the maternal safety. Along with the routine investigation, we have to do the investigation directed towards this hypertension, that is thinking about the preeclampsia and eclampsia, and along with the fetal safety. As such, as we are doing the complete blood count, complete urine examination, the investigation directed to liver function, thinking about the HELP syndrome, thinking about the kidney disease, we have to do the serum creatinine, BUN, naturally. About the urine protein examination is very important in these cases, and dipstick. We give the dipstick for urine protein examination, which a patient is doing at her home usually daily. If you want to ask me about the target blood pressure in the woman, there may be two types of women: without the comorbid condition or women with the comorbid condition. It is said that because here you have written the with the comorbid condition, the BP should be between 130 to 155. And diastolic BP should be 80 to 105. Although my husband is a physician, he always says that BP should be below 130 or equal, and the diastolic BP should be between 80 to 90, even in these all the patients.
Absolutely.
Yeah. And
hey, doctor, rename yourself.
Table. This is very important table that we have to provide each and every patient of such type. They have to do the monitoring on and recording on this type of the chart every day. This sheet is valid for 1 week, and the patient has to record her BP and bring to the doctor whenever she comes to us. BP should be recorded very properly in a sitting position, and along with this, she has to do the urine albumin, has to record that, lab test, that all we have told. She should be conscious of the warning sign and symptom, and antenatal checkup should be weekly, and fetal monitoring is very important, which we have to counsel to these patients. Patient should do the fetal kick count daily, NST at least weekly, and ultrasound evaluation is very important. That is for AFI, that is weekly or twice weekly. AFI should be done. Estimated fetal weight every 2 to 3 weeks, and even the Doppler flow studies are very important for these patients.
Thank you, Dr. Kanchan. Dr. GB, what antihypertensive should be used in pregnancy, and what is your drug of choice?
Dr. Gunjan?
If not, Dr. Nikhil Anand, you can take, or Dr. Akshay Shah, you can take over.
Hi, Dr. Nikhil Anand here.
So coming
Yes.
to the question, what antihypertensive could be the best choice? So right now, according to the guidelines, the tablet labetalol is should be the first choice. Methyl dopa was
Yes.
available previously; it was a first choice previously, but right now
Nowadays,
we
it is not available.
not available, and it has been replaced in all the guidelines that labetalol should be the first line of drug. You can start with 100 milligram BD and titrate accordingly. So you can maximally give up to 1200 milligram per day, but routinely we give 100 milligram TDS or 200 milligram TDS at a maximum. And if the patient is not controlled with this medication, then we can add another drug. The second line of drug should be the nifedipine. Nifedipine 10
Yes.
milligram, 1 TDS or in a sustained release is a good is a good second choice of drug in these cases. Hydralazine and nitroprusides are the available for the only emergencies. We do not use routinely in as such in our clinical practice.
So, Dr. Mahesh, if you have joined, can you tell us, is there any role of starting injectable low molecular weight heparin at this point? Or Dr. Raksha, you can take if Dr. Mahesh is not available.
Yes, sir. Sir, Devang bhai, you are not. I'm sorry, you are little less audible. Can you please say it little loudly?
Am I audible now?
Please.
Yes. So what is the role of injectable low molecular weight heparin at this point? Would you like to start after having a superimposed preeclampsia, or it is not at all indicated? What is
Or
the
not
evidence
at all?
and what is your experience?
So
Is asking what is the role of injection low molecular weight heparin?
yes, in perspective of what? In terms of
Chronic
hypertension?
hypertension with superimposed preeclampsia.
I don't think that low molecular weight heparin is at all important as far as the hypertension is concerned. What I said is that we should have started, I am of opinion of starting it in early pregnancy to prevent, because she has a previous 2 pregnancy loss, and I said it up to 12 weeks. That is essential. After that, based upon uterine artery Doppler, we can modify, or we cannot give it. We may not give it, but yes, aspirin 150 is of prime importance.
Okay. So the message we want to give here is that low molecular weight heparin after 16 weeks of pregnancy does not have much role. So later on in pregnancy, it should not be started. Now, Dr. Vishang, you would like to read this graph and guide us further regarding the fetal management?
Vishang Patel.
Yes, ma'am.
So if you can see here, the estimated fetal weight is going below the 3rd centile, and
it's a fetal growth restriction.
So how would you manage, Vishang?
In case of a fetal growth restriction, we will start with a weekly Doppler monitoring. There are 2 types of approach, maternal and fetal approach. Maternal approach starts with the BP monitoring, antihypertensive medications, and if she is already taking antihypertensive, then we will think of increasing or decreasing the dose. Then investigation, CBC, SGPT, serum creatinine, 24/20. We will look for imminent signs and symptoms of preeclampsia. About the fetal monitoring, we will go for a daily fetal movement charting. The Doppler should be done once or twice weekly. AFI and estimated fetal birth weight 2 weekly, and we can plan accordingly for the delivery. And we can plan for the bacterial prophylaxis if fetal growth restriction stage is there.
So, Dr. Didi, the patient complaining of headache at 34 weeks. Her BP is 160, 110. She is on labetalol 100 milligram 3 times a day, and also the 2 drug therapy, that is nifedipine 20 milligram 3 times a day. So how will you proceed on complete management in emergency? Please tell us, elaborate it. Is Dr. Didi there?
Dhaval is not there.
Otherwise, somebody else take.
Dr. Nikhil or Dr. Akshay can take.
Vishang, you can also take it.
As the BP is already 160, 110, the diastolic BP is touching 110. She is already having a headache at 34 weeks. She is already taking 2 different medications, labetalol 100 mg TDS and nifedipine 20 mg TDS. In this case, she has already crossed 34 weeks. We will go for the bacterial prophylaxis. We will go for the the magnesium sulfate prophylaxis for the neuroprotection of the baby, and then we will plan to terminate the pregnancy.
How will you do? Will you use
Okay.
magnesium sulfate?
Magnesium sulfate for the neuroprotection of the baby, and the magnesium prophylaxis for the lung maturation of the baby. The magnesium sulfate dose during, the blood pressure is already 110, the systolic blood pressure level. So magnesium sulfate prophylaxis should be there to prevent eclampsia.
Neuroprotection.
So it will be effective for both, for maternal
Yes.
as well as
Yeah.
fetal.
And
Yes.
the fetus.
Dr. Akshay, how will you decide the timing of delivery?
In this case, we are talking about, see, as the blood pressure is, is for crossing the normal blood pressure value, and she is having symptomatic. So I am of a same opinion that once we have been, we have given her betamethasone and magnesium sulfate, there is no need to further continue the pregnancy. But if if the blood pressure is under control and the symptoms are not prominent we are suspecting eclampsia, then we can decide based upon Doppler finding. So out of 3 points, Doppler, amniotic fluid, and fetal growth, of course it goes without saying that of utmost importance is fetal Doppler, right? So if we start from reverse, if it is a reversal of blood flow, it means, and if the viability is attained, then there is no need to further continue the pregnancy. Or if the age of viability is not attained, we can pull on and we can monitor with the help of ductus and aortic isthmus. As far as the IUGR is concerned, if the blood flow, but the Doppler is normal, if it is less than, if it has not fallen more than less than 3rd percentile fetal growth, as you have just narrated, we can pull on till the age of till 37 weeks of pregnancy. So based upon the Doppler, IUGR, and amniotic fluid, out of which amniotic fluid is of least importance, maternal symptoms are of most important, along with blood investigations and Doppler finding.
Perfect. Thank you so much.
Absolutely. So, peripartum, Dr. Nikhil Anand, can you tell us about when to stop ecosprin? What is the mode of anesthesia? What is the mode of delivery? What uterotonics would you like to use for safely? And what DVT, deep venous thrombosis, avoiding prophylaxis, would you suggest to such patient? Dr. Nikhil Anand.
Yeah, good evening, ma'am, and learned colleagues. Regarding ecosprin, we can say that if I can talk about generally, if the maturity is 37 weeks, we should stop the ecosprin. Or if we are planning for delivery in an emergency, then we should stop ecosprin as early as possible. Else, at the 37 week, we should stop it. That there is no need of further continuing pregnancy in a case of severe hypertension, which can lead to the eclampsia. So the ecosprin should be stopped ideally at the 37 weeks, or as we decide to deliver. Second is the mode of anesthesia. Mode of anesthesia is generally best decided by the anesthetist, looking to the picture, looking to the condition of the patient. But in such cases, when there is a severe hypertension, general anesthesia is more preferred than the epidural or regional anesthesia, because it will lead to control situation of the patient than the hypertension. Mode of delivery it depends on the obstetric reasons. Mode of delivery depends on the condition of the patient, whether patient is in labor or not, and the general condition of the maternal. If she is having eclampsia, then also we can deliver her vaginally by inducing with the cerebrim or mechanical induction. So I will not go for cesarean section directly in this type of cases. I will like to induce the patient first, depending on the Bishop score and the availability of my NICU setup. And if the induction fails, then we will go, or if the patient has having any other problems, we will go for the cesarean section. Secondly, cesarean section is electively indicated if there is another complications associated with the patient, like we cannot induce the patient in cases of previous CS or previous 2 CS, or if there is a absent fetal Doppler or a reversal of flow, then in that cases the already fetus is compromised. Fetus might not can take the stress of the delivery. In these cases, we can go for the elective cesarean sections. But if the fetus is not compromised, and we have to deliver by from the maternal case, then we can go for induction of labor and cesarean section if the induction fails.
Yeah,
Regarding
she responds to uterotonics also well.
Yeah.
As patients.
Responding to the uterotonics, we can safely give oxytocin. Methergine should be contraindicated in these patients. And misoprostol is a wonderful drug which can act immediately and can be used in various ways per rectal or per vaginal or even sublingual. So pre-delivery, you can use oxytocin. Post-delivery, methergine should not be used. And oxytocin, misoprostol, and even prostolone can be used.
Comment on DVT
Regarding DVT
prophylaxis.
prophylaxis, we can. It depends on. I think DVT prophylaxis should have a major factors or risk factors. If there is any risk factors for DVT, we can go for it. Otherwise, just because she is a case of previous severe preeclampsia, I would not like to include DVT prophylaxis for the world. You can
Very
give,
good, very good.
if there is a previous history of any thromboembolism or there is a diagnosed case of EPLA, then we can go for DVT prophylaxis. Or early ambulation is most helpful in this type of cases. We can advise patient for isometric exercises, leg moving and deep breathing exercise, and the early ambulation to decrease the DVT.
Very well said.
That's my clinical point of view. Experts can opine other way if needed. Thank you, ma'am.
Yeah, she delivered a preterm emergency and a female 1.4 kg was delivered. Next.
Now we move on to the next case. Madam, would you like to go ahead with the case? Varsha, madam. Okay. Am I audible?
Yes, yes.
Okay. So she's a lady who is 38 years old with BMI of 24, and she had previous to intrauterine fetal death at 32 weeks and 28 weeks with 700 grams, 900 grams. Then she had pre-pregnancy counseling and she delivered a male child 2.2 kg in 2021.
Devang bhai, you are not loud enough. I am sorry.
But you can read the slide and you can guess what he wants to ask.
Am I audible now?
Yes, sir. Better, sir. Quite better.
Okay. So she's a known case of gestational diabetes. She's on insulin, and she had she was also known case of SLE during pregnancy. Now she's chronically we see she is a diabetes type 2 patient with SLE, and her family history is also contributory. What would be the method of pre-pregnancy counseling? Dr. Kanchan Sharma.
Yes, sir. Yes, sir. Because as with the history, we all saying she's a patient of bad obstetric history with SLE, with type 2 diabetes, a very high risk pregnancy. So pre-pregnancy counseling is very, very important in this particular case. We have to make this is to save us as well as to the patient, because if we make understand to our patient that this is a disease who need a consultation with a multidisciplinary team, and we have to plan the pregnancy very wisely. You have to do pre-pregnancy investigations in which we have to see whether your SLE is not in active phase. It is said that SLE, when is active, patient should not conceive. At least 6 month duration should be given after that. So there are certain investigations in this, along with the routine investigation, all the CBC, liver function test, NCDs, DNA, along with that, investigation for lactate accumulation, LAC test, anti-cardiolipin antibody test, anti-B2 glycoprotein, renal function tests are very important. C3, C4 test is very important just for to monitor the autoimmune disorders. Others are kidney function test, uric acid, HbA1c is very important in these cases. in this particular case. And cardiac status, like 2D echo, and even fundus examination, because she is a diabetic patient also, so is very important. These all should be counseled very well, that before you conceive, all these investigations should be done, because if she get all these investigations, then she can plan the pregnancy better.
Yes.
Okay, Dr. GB, the next question is in SLE or lupus nephritis, when to say no or wait before planning pregnancy?
Dr. Gunjan is
Dr.
not there.
Akshaya, you can take it.
Yes,
What are
yes.
the
There are-
contraindications, relative contraindications?
Yes, as Devang Bhai has helped us a lot to prepare this question and answer. It is very obvious that in severe lupus flare, if there is a history in past 6 months, if there is a history of stroke, if there is a case of pulmonary hypertension, if there is a moderate to severe heart failure or severe valvulopathy, these are the cases. Along with if there is a severe restrictive lung disease, because this SLE causes serositis, especially of pericardium and pleural. So if there is a lung disease or
Yes.
pericarditis, that is serositis, that these are the contraindications that they should preferably avoid pregnancy till they are recovered. If there is a case of chronic kidney disease or uncontrolled hypertension, or if there is a previous severe early pregnancy induced hypertension history less than 28 weeks, or pre-eclampsia or HELLP syndrome, they should they should first be controlled as far as the SLE is concerned, then only they should plan pregnancy.
Absolutely.
Now she becomes pregnant and she comes to us and she is having severe vomiting. So what complications you would like to look for, considering she is diabetic and on insulin?
See, if it is
Jariwala is not there, somebody take it.
if it is an uncontrolled diabetes, either severe hypoglycemia or hyperglycemia, that can cause metabolic disturbances, or if there is a major profound thyroid imbalance. But we have to be very careful in labeling the patient as a case of hyperthyroidism, because early pregnancy there is a similarity of beta HCG with thyrotropin releasing hormone. So that before stamping her as a hyperthyroid, we have to confirm with the help of free T3, free T4 and TPO antibodies, because of the molecular similarity of beta HCG hormone and thyrotropin releasing hormone, this may mimic like hyperthyroidism, which may not be actually.
Yes. Dr. Vipul Shah, Vipul Patel, Vishang Patel, the TSS is less than 0.001. What to do?
Ma'am, the TSS is less than 0.001. We will like to go for the free T3 and free T4. And we would like to look for whether it is the actual hyperthyroidism or it is a subclinical hyperthyroidism. And according to the levels of the free T4, we can start treatment with the PTU.
Okay.
So yes, but it turned out to be normal and we continue. So the message you want to give here is that if free thyroid profile is normal, you just need to wait and watch.
Watch, yes.
Yes. How would you monitor and manage in antenatal period? Dr. Dhaval is not there. Dr. Nikhil, would you like to take this?
Yeah. Good evening, Dr. Devang. Regarding the what we have to do if there is a how to monitor these patients. So obviously in any of the patients we have to monitor both the mother as well as fetus. So for the maternal point of view, we can see that we have to decide about the what is actual condition of the patient, and we in this, because these are very high risk patients, proper counseling is absolutely must in these cases. So we have to go for the actual the pros and cons of various diseases and how it affects the maternal condition, how it affects the fetal condition. That should be known to the mother, ideally before pregnancy, starting from the pregnancy. We have to investigate the mother, as we have already discussed, that we have to discuss about the routine. Apart from the routine, our antidote profiles, we have to go for the TSH values and the creatinine RFT LFT values. Obviously, we have to go for this. This is a case of diabetes. So HbA1c repetition, if provided, it is a must. Apart
Yes,
from
so
that,
exactly. So close monitoring is required throughout pregnancy of all the blood sugar and the medicines. So how would you manage and control the blood sugar, Dr. Akshay?
Yes, sir. See, as we all know, since our undergraduate days, what is more important is that maternal nutritional therapy, which includes lifestyle modifications, physical exercise, and nutritional based dietary advices, especially in terms of glucose, that is carbohydrate, to avoid to switch over to unsaturated fatty acids instead of saturated fatty acids. And we need to guide her for small frequent feeds. As far as the carbohydrates are concerned, we need to make her aware about low glycemic index kind of sources like legumes, whole fruits, vegetables, right? So that is about maternal nutritional therapy. Second is lifestyle modifications, especially to avoid tobacco and alcohol and cigarette, which is, I'm sorry to say that nowadays very, very common. So that is somebody. Okay. And third is monitoring of blood sugar, that is self-monitoring of blood glucose. There are
Yes.
different protocols for the same. That is, we can monitor, we can ask her initially once it is detected in early days when we are titrating the dose, or yes, when we are deciding the treatment modalities, that can be managed daily, monitored daily or alternate day. The target is fasting less than 95, after 1 hour less than 140, and after 2 hours of lunch should be less than 120. We have to be very sure that we are avoiding hypoglycemia at night time, and when obviously, you know, most of the people are not taking food at night, it should be kept above 60 milligram per deciliter level.
Yes. Dr. Nikhil Anand, tell us about the insulin. How will you give, how much, and what are the types and everything?
In short.
yeah, good evening, madam, and good evening to our colleagues. Regarding insulin therapy, basically, as an obstetrician, I would not like to introduce the insulin to the patient by myself. I would restrict myself to the medical nutrition therapy and exercise.
Yes.
If it is not controlled with the help of a proper diabetologist, or if diabetes is not available, then a physician, I would like to introduce the patient to the insulin therapy. Insulin therapy is introduced only when there is a medical nutritional therapy fails, and after even after 1 week, and sugar is not controlled, then we have to introduce insulin. So insulin should be given basically if the patient is not having a severe hyperglycemia, and then we can start about the routine doses of insulin. That is a regular insulin, 2/3 dose should be given at the morning, and 1/3 dose should be given at the night. But if the patient is having a severe hyperglycemia, then we have to admit the patient and start insulin on the sliding scale. Once the patient is euglycemic, then we can switch over to the longer acting insulin.
Absolutely. So these are the, okay. Yes, Dr. Deva.
So, Dr. Kancha ma'am, can you guide us what medicines we can use during pregnancy? What are the anti-diabetic agents of choice during pregnancy to control blood sugar?
Yeah, actually, Dr. Devang sir, as we see that the insulin is the best, but in case the patients are willing for the oral anti-diabetic agents, then we have two category of the drugs, non-sulfonylurea and the sulfonylurea. Non-sulfonylurea, they include biguanide. These are the metformin which we all are using. These are the insulin sensitizers. And there are many trials also that we still are using. Now we have a sustained release type of the metformin also. Even 500 milligram, even 1000 OD sustained release we are using. And other is the glyburide or sulfonylurea. That includes, there is some disturbance, tolbutamine and the chloropropamide. these are what happens, that is in the category C type. What happens with these medicines? There is a sharp hypoglycemia with this type of medicine. So better we use this bigonides. These are two types of the drugs.
Yes.
Best is the insulin.
So
Okay, Dr. GB, he's
Question
not
is
there.
from
Dr.
the
Devang
Vishal
Patel,
Patel.
sorry, Dr. Akshay Shah, you can take this. What are the antenatal management for SLE?
Yes.
How
So
can you proceed for managing such case?
see, we need to counsel her about, we need to counsel the patient and relative about SLE and its consequences and occasional flare which can occur during pregnancy. So we need to carry out certain basic investigations as far as the SLE is concerned. That is urine analysis, complete blood count, serum creatinine, and the specific investigation, that is anti-double stranded DNA antibody, right? Based. Hello,
Yes.
I'm audible.
Yes, yes.
Yes, yes.
So, yes, every month we need to follow up with the help of this blood investigations, especially urine analysis, and in 24-hour protein, 24-hour urine protein creatinine ratio, which is more reliable than a spot urine sample. And even so, if we say that only spot urine creatinine, or 24-hour protein and creatinine, the protein creatinine is more reliable. Like blood urea nitrogen is more, in certain studies have said that blood urea nitrogen is more reliable than simple blood urea, right? So that's how every trimester we need to monitor her for SLE. And if there is a flare, or if she is on, obviously she will be on medicine such as hydroxychloroquine, and
Sir,
that
you are
can help her to control.
You are perfectly right in
Okay.
this. So the main
Yeah,
purpose is
absolutely.
to detect the flare in the very early phase. So that is the main purpose. And now the next question is, if the patient was on HCQS before pregnancy, would you like to stop or continue, and why? Dr. Akshay sir, would you like to take it?
Sir, hydroxychloroquine is safe in pregnancy.
Exactly.
That there is no need to stop it.
Exactly. Dr. Vishang, would you like to guide us regarding the different medicines which are used, whether they are safe or not? Dr. Vishang.
Sir, hydroxychloroquine and azathioprine both are safe, but more commonly, clinically, hydroxychloroquine is used by most of the rheumatologists or internal medicine specialists, right? And if needed, that can always be supplemented with the help of corticosteroids, especially when there is a flare. So the common drugs which are being practically used are hydroxychloroquine, sometimes azathioprine, and steroids.
One more important thing is mycophenolate is used very rampantly in the non-pregnant state, and many times the patients may not stop it. So if that is there, then that has to be stopped immediately, because that is a category E drug. Now many patients also ask, ma'am, Varsha ma'am.
Okay, Vishang Patel, steroid will harm my baby. Shall I stop? This is always the problem with patients who read Google and who have half knowledge. And but their fear is also justified. So how will you counsel them?
The low dose steroids will help in a case of SLE and will help in preventing the flare. So the steroids in low dose will not harm the baby. We will counsel the patient regarding the same. Actually, it is category C drug, but the steroids in low dose will not harm the baby. As if the patient is already taking the hydroxychloroquine, we will continue the hydroxychloroquine and with the addition of the low dose steroid. Corticosteroid has been associated with hyperglycemia or osteoporosis or immunosuppression and some fetal malformation. But in acute cases of SLE, the low dose should be given.
Okay, right, absolutely. But it should suffice for giving the effect also.
But the risk, yes, the benefit is more than the risk.
So the thing is, when the patient is on chronic steroids, she's at risk of hyperglycemia. So sugar has to be monitored, and osteoporosis. So calcium, vitamin D3 supplementation should not be missed in all these cases. Our patient was on HCQS, omnacortil, ecosprin, low molecular weight, heparin, metformin, and actrapid for blood sugar. And when we move ahead, Dr. Dhaval is not there. Dr. Nikhil, would you like to tell us which scans you would like to see for this patient for fetal monitoring?
Yeah, as the patient is a known case of SLE with diabetes, she is at high risk of having congenital anomalies. So we should first counsel the patient regarding the same, and we should advise for the proper ultrasound anomaly scan for the same. So basically, in the first trimester ultrasound scan will rule out the first trimester anomalies, likewise NNK and at 14 to 16 weeks we can look for the neural tube defects. Prenatal screening, if patient is presented to us before conception, we can go for a prenatal screening. But if this patient is pregnant, so we can go for the first trimester scan. Then TIFA scan is
Sorry,
also should be
in
done.
this case, the patient is 38 years old. So which screening test would you like to advise? Only one word answer.
Hello.
Advanced maternal age. Which prenatal screening? Double marker, NIPT. Which would you like to do?
No.
NIPT, sir.
Yes.
Hello.
So that is a more accurate test, more sensitivity, and fetal echo is of importance in such cases because of the risk of congenital heart block as well as congenital anomalies due to increased blood sugar. And Akshay sir,
This is the case of at 28 weeks, she complains of rashes. Blood pressure is 130/84, HB8, platelet 90,000, urine protein +3, serum creatinine 1.2. So, what is the differential diagnosis, and how will you differentiate? Anybody can take it.
See, there are. Yes, sir. Sir, first of all, S is a known case of SLE. The first thing we should strike our mind is there is a possibility of flare, especially who has active disease at conception, or if there is a prior history of renal disease, they are more prone to develop flare. But otherwise, that can happen to other patients as well. Other differential diagnosis, as we know that is possible in case of HELLP syndrome. It is possible in case of pregnancy-induced hypertension. It is possible in case of dengue, right? So these are the things needs to be differentiated. So based upon symptoms, if in case of SLE, which is more likely in this case, there is a neutropenia along with thrombocytopenia. That is one. If you go in the history, if there is a history of fatigue, joint pain, or hair loss, which is typical of SLE, which doesn't occur in rest of the conditions, so we will suspect SLE more likely. And as mentioned, liver function tests are usually not changed in this SLE, and the specific tests are anti-double stranded DNA antibody and C3C4 complement. If they are detected, that goes more obviously, that proves that it is a case of SLE flare up.
So, Dr. Nikhil, now patient is already on omnacortil, and now would you like to give her betamethasone for fetal lung maturity? Yes or no, and why? Dr. Nikhil.
Dr. Nikhil Anand.
Hello.
Yes.
Yes, Dr. Nikhil Anand.
Yeah. Good evening. I would like to give betamethasone because the omnacortil, though it's a steroid, the effect of omnacortil and betamethasone are quite different on the lungs. So for the lung maturity, I would like to give the betamethasone.
And second thing, that prednisolone will not go to the fetus because there is one placental enzyme which is beta-hydroxysteroid dehydrogenase, which will metabolize it, while betamethasone and dexamethasone will reach the fetus. Good. So, Dr. Kanchan, would you guide us when to deliver depending on the pathology?
Yes, sir.
What gestational age would you like to pull on?
Yes, sir. Thank you very much for the question. This is very important that when to deliver, because our aim is to get the healthy mother as well as the healthy fetus. just this all depends on the complication in mother and the fetus which we see monitor, and if whether this is a pre-gestational diabetes or this is a gestational diabetes, we see if it is uncomplicated. We have to fulfill our aim of the lung maturity as well as the fetal full development till the 39 weeks. We will deliver it. If it is a complicated pregnancy, there is many complication or there is a risk of the fetus that we see on the color Doppler and the different parameters, then our aim will be to carry the pregnancy till the 36-37 weeks, at least till the lung maturity develop. If because of any other complication or the previous demise or any history that suggests that we have to deliver it even before this, then after giving the medicine for the fetal lung maturity, and with the full preparation of the NICU, we can even deliver in those cases before this.
Okay, Dr. Vishank Patel, low molecular weight heparin before delivery, when to stop?
Ideally, the LMWH is a two-edged sword. It can lead to increased incidence of bleeding. But in cases of SLE, LMWH before delivery should be, the prophylactic dose should be given 12 hours before, and the therapeutic dose should be given 24 hours. After delivery, we can start as soon as 4 hours, we can start the LMWH.
Yes, so prophylactic dose is 0.5 mg per kg per day, and that has to be stopped 12 hours before the planned procedure. And therapeutic dose, if it is 1 mg per kg per day, then it has to be stopped 24 hours before the procedure to decrease the risk of bleeding. Exactly. And what is the stress dose of steroid? Dr. Akshay?
Hello. Yeah, that is. Hello, sorry. Devang bhai.
What is stress dose of steroid which we give during labor?
No, I'm sorry, I'm not aware.
Okay. Dr. Vishang or anyone would like to take it?
The stress dose is because of the long prescription of the steroids, it leads to SP axis suppression. So we give 100 mg intravenous hydrocortisone during labor.
So that will prevent the adrenal crisis. So continuous fetal monitoring. And Dr. Vishang, how would you control the blood sugar during labor?
The intrapartum, we can go for the 2-hour sugar monitoring. We can monitor the vitals every hourly. Serum electrolyte should be done when the patient is admitted. If the blood sugar level is below 80, the blood sugar level, then there is no need of insulin. If the patient is already on insulin, then according to the sugar charting, we can start the insulin from 80 to 300. Our goal should be to manage the blood sugar level at least between 80 to 160. If the sugar level is going more than 300, then the expert opinion should be there.
So with your
she underwent induction of labor at 37 weeks and then failed so landed into emergency cesarean section, and we could deliver a female baby 2.8 kg, which was normal. So in conclusion, dear panelists and Dr. Devang Patel, you have really given great highlight how to manage and how to prevent and what are the complications. So in conclusion, multidisciplinary team approach is very important. Identification of risk factor, intervention at right time, manage at the tertiary perinatal center is very, very important. Majority of medications are safe in appropriate doses, and improved maternal mortality and morbidity is utmost priority of each and every obstetrician and multidisciplinary approach is very, very important to save the child and to give better treatment to the mother, and timely decision, timely everything, and is timely monitoring, timely timely interventions are of great help to save the mother and baby. Thank you for a very nice, elaborate session, Dr. Devang Patel. I really thank you for preparing that presentation in a very, very well manner, high standard of academics. And really thankful to all the esteemed panelists also, Dr. Akshay Shah, Vishang Patel, Dr. Kanchan Sharma, Dr. Farhan, Dr. Chandni, everybody who were the who involved themselves in this great webinar and delivered all the knowledge to improve the audience knowledge, and great updates and take-home messages also we could get. Thank you everybody for participation and giving time to be here and give your inputs also. I'm really thankful to everybody, especially to Dr. Devang Patel for preparing the slides and presentations, so exhaustive, elaborate presentation. Really thankful to each and everybody, and I'm thankful to Saiti, the web designer, and Nishan, who is the Shield Pharma person who gave us the great platform of Zoom, and I can see Dr. Chandani, Dr. Foram Acharya, who were the chairperson also. And thank you, Dr. Kanchan Verma. Wish you all the best for your endeavors. And everybody, thank you so much for being here. Dhanyawad.
Thank you,
Radhe, Radhe.
Varshadi. You
Thank
did
you, ma'am.
wonders, and you are always very good. And thank you for arranging such a wonderful webinar and in giving the job of this wonderful panel moderation
Let
to
me
Dr. Devang Patel.
tell all the audience, I am going for the post of Vice President Foxy West Zone. So, मेरा चेहरा देखना और सिक्का मारना. Thank you so much. Radhe,
Thank you.
Radhe.
And
Thank
same
you.
here,
Love
I'm
you
going
all.
for NCD committee chairperson. So kindly, I need your all blessing from the Gujarat Society. Please bless me for the task.
Thank
And
you.
my
Good night.
future.
Chabba khair.
All the best.
Dhanyawad. Radhe, Radhe.
Okay. Good night.